we start with Mycoplasma genitalium. So why this topic is very important? Because this is an emerging STI. It is associated with a persistent urethritis, cervicitis, pelvic inflammatory disease, and it is has got an increasing relevance in subfertility, recurrent STI symptoms. Okay, so these are the important points about the infection with the mycoplasma. Okay, there are certain guidelines. What does the guideline says? You have to test Mycoplasma genitalium in all patients with non-gonococcal urethritis. If you are having a persistent, recurrent non-gonococcal urethritis, you have to test them for Mycoplasma genitalium. Then you have to test Mycoplasma genitalium in individuals with symptoms of PID. Okay, so generally in male it will be urethritis presentation, in females it may be PID. So if it is a persistent, then you will definitely test these patients for mycoplasma also. Test current sexual partners of persons infected with mycoplasma. Now you have diagnosed the mycoplasma infection, you will test the current sexual partners also. Okay, and for male, the first void urine is the specimen of choice, because it is a presentation, it is a non-gonococcal urethritis or NGU type of presentation is there. So sample will be first void urine. Okay, in females it is a vaginal swab, either penetration or self-taken, that is the choice in females. Okay, and all Mycoplasma genitalium positive specimen should be tested for macrolide resistance. Okay, so this macrolide resistance for mycoplasma is must. Okay, and mycoplasma treatment is a chlamydia plus azithro. Okay, 3 days azithro you have to add. So the treatment is a doxy 100 milligram BD for 7 days. That is the treatment of chlamydia, followed by azithro 1 gram stat, followed plus 500 milligram OD for 2 days. Okay, so 7 days of doxy plus 3 days of azithro. Azithro is given 1 gram stat and 500 OD for 2 days. Okay, another option is moxifloxacin. You give 400 milligram OD for 10 days. Okay. Yes, I totally agree, doctor. This treatment regime for each. And not only that, there are certain things which they specifically ask. First thing, there are many STIs. Then these STIs, they have got a different presentation. Okay, there is a first line treatment, there is a second line treatment. Suppose in the first line treatment, the patient is allergic to some other medicine, then what drug should be used? Then there are certain pregnancy related. So you may have specific infection in pregnancy. So the drug of choice may be different. So there is no point in remembering only the first line drug. We have to know the first line drug for non-pregnant women, first line drug for the pregnant women. We should know if the patient is allergic to the first line, what drug should be used. If the patient is HIV positive, what is the drug of choice and what is the duration. That is how we need to know this particular topic. Okay, so still we are using certain short tricks and things to remember, which is recommended. That is doxy 100 milligram BD for 7 days, followed by azi 1 gram stat plus 500 OD for 2 days. Alternative is a moxifloxacin 400 OD for 10 days. Okay. So azithromycin monotherapy is no longer the first line resistant. If it is a complicated infection, then moxifloxacin 400 OD for 14 days. Okay. So what are the alternative? Doxy 7 days followed by pristinamycin for 10 days. So instead of azi for 3 days, you can use pristinamycin QID for 10 days. Then pristinamycin QID alone can be used for 10 days. Then doxy alone can be used for 14 days and minocycline 100 BD for 14 days. So these are the alternative treatment regimen secondary to the what we have seen. Okay. Now coming to the test of cure. Test of cure will be done at 5 weeks and not earlier than 3 weeks after the start of the treatment to ensure the microbiological cure. Okay. So persistent NGU, we will always think of mycoplasma. It does not have cell wall, so penicillin is not effective. NAAT is the test. Culture is impractical and major cause of persistent urethritis linked to PID but not proven tubal infertility. Okay. Do not screen asymptomatic individuals. Okay. General population.
So the mycoplasma, sir, the diagnosis is only if it is persistent or recurrent. No definite test to diagnose it.
No, nothing. Basically, the presentation will be non-gonococcal urethritis in females, so in males, and persistent PID, which is not responding to the routine line of treatment. Okay.
The resistance type of PID
picture will be there.
Strong,
so
and there is no other
the
diagnostic
test of choice will be NAAT only you have to do. NAAT only they have mentioned. Yeah.
Okay. NAAT only and no culture can be
Culture
possible
is
because there is
impractical
no
because
cell wall.
this organism is a different type only, no?
No
So
cell wall.
culture, and there is no cell wall, so there must be some limitations in the culture also. So NAAT is the only treatment. Okay.
Okay.
So these epidemiological things, general population around 1 to 2%, but high STI in the STI clinics. So what are the risk factors? Young age, non-white ethnicity, smoking, and multiple sexual partners. So what is the key difference from chlamydia? So prevalence peak is latter. We have seen chlamydia very typical, less than 25 years of age group. Okay. Here the peak is little latter. It remains higher in older age group. Sexual transmitted infection, strong partner concordance, and partners are more likely to be infected. Genetically identical strains in the partners you get. Main route is a genito-genital contact. Then penile anal transmission is known. Oral transmission is minimal. These are not very important or exam-oriented questions. Okay, but the co-infection is known. Chlamydia trachomatis most commonly associated with mycoplasma. Association with HIV acquisition and transmission. Okay, so with HIV also it has got an association. So many cases are asymptomatic both in males as well as female. In males, dysuria, urethral discharge, penile irritation, and urethritis. These are the presentation. While in females, dysuria is the presentation, and sometimes the post-coital bleeding also. Okay, so this is also one of the common presentation. Mycoplasma will present with the post-coital bleeding. Okay, there may be intermenstrual bleeding, cervicitis, lower abdominal pain. So these are the features associated with the mycoplasma. So infection may be asymptomatic. Symptomatic rate is less than 10%. Most infections will be asymptomatic. Okay. So natural history is that infection may persist for months or years. So mycoplasma is known for persistence of infection. Okay. Screening of asymptomatic population is not recommended. So if you have got an asymptomatic partner of a symptomatic case, then what is the management? Okay, then you have to test and or treat that particular patient. So you have got a index case and the partner is asymptomatic. You will test and or treat. Okay, so testing is also required and treatment is also required. Okay, so partner treatment, prevention of reinfection of index case. So why partner is to be treated? Because the index case should not have reinfection. Okay.